over 60% of adults, and in some counties the obesity rates are over 70%. People with low education levels and lower incomes have higher rates of obesity and overweight, as do African Americans, Latinos, American Indians, and Pacific Islanders. The costs of these high prevalence of overweight and obesity are remarkable. In 2000, a study commissioned by the California Department of Health Services estimated that physical inactivity, obesity, and overweight cost California nearly $22 billion in direct medical costs and the costs of workers' compensation and lost productivity. By 2006, a similar study estimated that the costs had risen to $41 billion, nearly a doubling in less than a decade. If we could reduce overweight, obesity, and inactivity by just 5%, we expect to see a savings of about $2.4 billion each year. Obesity-related chronic diseases and costs are also increasing rapidly. Dr. Kaufman mentioned the huge increase in the rates of diabetes in the last decade. Right now, about 2.7 million California adults, or about 1 in 10, have diabetes, and the estimated costs for diabetes in California are about $24 billion annually. The total California cost for cardiovascular disease, which is the leading cause of death in California, is about $57 billion. And a recent study predicted that in less than 15 years, the costs of preventable chronic disease in the state will be about $117 billion. We clearly need to change this trajectory. In the past 5 years, Governor Schwarzenegger has signed a number of landmark bills. I won't go through them. You're familiar with them. And we also, of course, are proud of our programs like food stamps, free and reduced price meals, and WIC that provide opportunities for low-income individuals to have better access to healthy foods and vegetables and whole grains. But these actions and programs alone will not be enough to reverse the obesity epidemic. So I want to talk very quickly about lessons from our tobacco control program that might be applicable to our efforts to address the obesity epidemic. The passage of Prop 99, the California Tobacco Tax and Health Promotion Act, enabled California to become the first state to implement an aggressive, comprehensive statewide tobacco control program. As a result, adult smoking prevalence has been reduced by 41%, and per capita cigarette consumption declined by more than 60%, while in the rest of the nation, that rate went down just 40%. Most important, rates of lung cancer decreased 4 times faster in California than the rest of the nation. California's tobacco control program has saved 1 million lives and $86 billion in health care costs in its first 15 years. That's a 50-fold return on investment. The tobacco control model rests on 3 basic concepts. 1, changing social norms surrounding tobacco use to create a social and legal climate where tobacco is less desirable and less acceptable, including through countering of tobacco industry marketing. 2, changing the environment so that tobacco is less accessible and secondhand exposure is reduced. This has been achieved through raising the cost with the tobacco tax and through state and local policy to limit the places where tobacco can be used and sold. And 3rd, through increasing access to cessation services. Tobacco control worked because it was a concerted, long-term effort that coordinated strategies at the state, local, and community levels with very substantial support of those strategies to the tune of over $2 billion over 20 years. Despite our successful interventions and investment, we still have 4 million smokers in California. What I take from this experience is that there is no easy or fast fix to address the obesity epidemic. Increasing consumption of healthy beverages and decreasing consumption of unhealthy beverages is one important approach. We need to find ways to support a sustained and coordinated strategy that incorporates community-based, local, and state government action so that we can change our social, physical, and economic environments in ways that make healthy choices the easier choices. Thank you.
Thank you. Next presenter, please.
Thank you. My name is Marion Standish, and I'm very pleased to be here on behalf of Dr. Ross, who unfortunately had to leave. And thank you very much to Senator Padilla and Flores for and Alquist for hosting this hearing and allowing us to be a part of it. The California Endowment has been working for many years on multiple fronts to tackle the obesity crisis. Over the last 6 years, we have supported community-based organizations, public health departments, schools, and many, many other players in other sectors to work aggressively to build the evidence, to develop experience, and to change local and statewide policies towards the effort of reversing the obesity epidemic. We've spent over $70 million in the last 6 years towards this effort. And I think we have learned a lot, and we have a good sense of what works and what needs to be done to move our state and our communities further, faster in reversing the epidemic. We can't wait for the science to be any clearer than it is, and as we've heard today, and communities all over the state are mobilized to act on what they know and what they see in front of them. I might add also, just in the context of our testimony today on oral health, that we have also invested $15 million in fluoridation, and we know prevention works. But it works in concert with many other actors and many other efforts that need to be a part of the solution. We've made important strides. We know now that when children particularly are given healthy choices, they make healthy choices. We know that in the context of our groundbreaking legislation here in the state to change the beverage environment in schools, and that young people are making the healthy choices when it's available to them. But as I said, we need to do more, and we need to be much more ambitious and aggressive in our local efforts and our policy efforts. So let me just cut to the chase and highlight what we think are some important policy directions that this committee might consider and those in the audience might consider. First, we definitely believe that pricing strategies are appropriate for us to examine and look at and consider. We know that water, in many instances, is more expensive than sweetened beverages, and that doesn't make any sense, quite candidly. We know that in the school environment, where we have made many strides, as I said before, we still have sports drinks available in vending machines in schools. Whether they are lower in calorie and lower in sugar content, they are still too high in calorie and too high in sugar content. And from our point of view, there's no reason why sports drinks should be available in vending machines in school. Similarly, we think it's important to examine whether water is available in schools and freely available in schools. Students shouldn't have to buy water, particularly in low-income schools, and we know and understand from research underway that there is a problem with free water availability in school, and we think that would make a big difference. I think there is a great deal that can be done on labeling and certainly on marketing, and I won't go into that since we've heard so much of that today, but I think those are also important policy goals that we can strive for. Again, I think communities are ready. They are anxious to see change. They see the impact and the devastation of obesity and diabetes in their communities, in their families every day. And I think we have the evidence, we have the science, and we need to move forward and move forward quickly. Thank you for the opportunity to be here.
Thank you.
Senators, it's an honor to be with you here today. My name is Genoveva Islas Hooker. I'm the Regional Program Coordinator for the Central California Regional Obesity Prevention Program. We're a partnership between public health departments, community-based organizations, and grassroots community members. I'm also